Our next speaker is well known as well, Dr. Michelle Petrie from Hopkins and the Hopkins Lupus Clinic. I heard her 8 years ago in Dubai say crazy things about lupus, but it's changed, and now there's new rules on lupus. Let's hear what Dr. Petrie has to say about new rules on steroids in lupus.
Hi, I'm Michelle Petrie, and I'm going to be talking about new steroid rules for lupus. Here are my disclosures. So here's the first subject. We find the metabolic side effects of steroids early, and those are things like the cholesterol going up, diabetes, hypertension. But the permanent organ damage often isn't found until later. Here you see the organ damage plotted by organ in my African American patients on the left and my Caucasian patients on the right. The letter M stands for musculoskeletal system, and you see that's the most common organ damaged in both races, representing mostly osteoporotic fractures, but also osteonecrosis. Obviously, that's almost completely driven by corticosteroids. Now, the second most common organ damage is different in the different races. So in African Americans on the left, you see it's R for renal. But for Caucasians, it's N for neurologic, and that's mostly represented by strokes. We have proven in this prospective analysis that cardiovascular events, meaning myocardial infarction and stroke, are independently predicted by the prednisone dose. So if the prednisone maintenance dose is 10 milligrams, the risk goes up 2.4-fold. And if the maintenance dose is 20 milligrams, the risk goes up 5-fold. These models included not just the disease activity, but also the traditional cardiovascular risk factors. In another prospective longitudinal analysis, I actually looked at the mean daily prednisone dose. But what's key about this model is that we were able to adjust for confounding by indication, because obviously there was a reason I prescribed the prednisone, and that was to control the lupus disease activity. If the prednisone dose is kept below 6 milligrams, there was only a 16% increase in permanent organ damage. But the minute it got to 6 milligrams or more, there was a 50% increase. And you can see if the maintenance prednisone dose is above 18 milligrams, there's over a 2.5-fold increase in later organ damage. So let's put all this together in a simple way that you and I can apply in clinic with just simple arithmetic. So this looks like a really complicated Cox proportional hazard model. It's the time to organ damage. And you can see there are lots of risk factors, aren't there, including disease activity. But I just want you to look at the last line. So if you or I decide to increase prednisone by 1 milligram, there will be a 3% increase in later organ damage. So you can do this easily in your head. If you decide to increase prednisone by 10 milligrams, there will be a 30% increase in later organ damage. I think this is enough to make you feel guilty and enough to look around for a different path forward. So here's my second subject. Some recommendations are never going to be implemented in real-world practice, but the EULAR 2023 guidelines will be. So the previous EULAR guidelines for lupus had accepted 7.5 milligrams of prednisone as the daily goal. But now that's changed. Now, I was on this committee, but I promise you I didn't have to strong-arm the other members. This is a unanimous recommendation. The maintenance prednisone should be 5 milligrams a day or less, and if at all possible, withdrawn entirely. Now, it is permissible to use pulses of intravenous methylprednisolone to control disease activity. And I would actually add to this using an intramuscular triamcinolone injection, as we'll discuss later. Now, how are we going to do this? Obviously, we're going to have everybody on hydroxychloroquine, right? But the key here is if we're unable to taper glucocorticoids to 5 milligrams or less, these guidelines clearly state we need to introduce immunosuppressive or immunomodulatory drugs and or biologics. You see that key word there, or? This means you don't have to do a step approach of having the patient fail multiple immunosuppressive drugs before you go to biologics. If the biologic is the right choice for that patient at that time, you can go directly to it. Now, the problem with guidelines, of course, is there are traps. I'm going to call these corticosteroid traps, where you and I end up using corticosteroids, and there's going to be a consequence for the patient. So the first example is bridging. Now, I know a bridge sounds like a good idea, doesn't it? It sounds like this is the Biden infrastructure plan, and there should be bipartisan support. The problem is the way physicians use the term bridging is we mean giving corticosteroids while we're waiting for our best therapy to take effect, meaning an immunosuppressive drug and or a biologic. So how long can you bridge? Well, I hope this will shock you. This is our prospective analysis of osteonecrosis. And it turns out that just 1 month of 40 or 60 milligrams is enough to increase the risk. Or more than 1 month, like 6 weeks, at 20 milligrams. So you cannot get away with bridging for longer than a month at these doses of glucocorticoids. Now, what about flares? Because that's an obvious trap. And gosh, I see this happen all the time, and I know you do, when your patient goes to the emergency room. They get on an astoundingly high dose of oral corticosteroids, and you often don't hear about it until a subsequent follow-up visit when it's too late. So when your patient is facing a flare, and I mean something that's non-life-threatening, like a skin flare, a joint flare, a serositis flare, we did this randomized trial, randomizing patients to a methylprednisolone dose pack or intramuscular triamcinolone 100 milligrams. And by 1 month, the great majority of patients were doing fine on either therapy. So I think it's possible for most flares to treat with this small burst and not to increase the daily oral corticosteroid dose. But my fourth topic is truly real life. And my statement here is prednisone a necessary evil? And I'm afraid lupus nephritis is still that major hangup. So here is an analysis recently published by Ali Duarte and colleagues. This is a meta-regression of the placebo groups of multiple randomized lupus nephritis trials. Now, first in red, you see that patients who receive pulse methylprednisolone are more likely to achieve a complete renal response at 1 year. Well, that's an important take-home message, isn't it? And remember, the EULAR 2023 guidelines make it clear that pulse methylprednisolone is allowed. But what you see in blue is clearly stated that as the oral prednisone dose goes up, so does the complete renal response at 1 year. And this includes, by the way, that 60 milligram dose, which is pretty much the 1 milligram per kilogram. But as you know, the EULAR lupus nephritis guidelines have recommended 0.5 milligrams per kilogram as the top dose, So for most patients, let's say 20 to 25 milligrams a day with rapid taper. Why can we get away with less oral corticosteroids? Well, only if we also follow the ACR lupus nephritis guidelines, so we don't use mycophenolate alone. When we first diagnose lupus nephritis, we need to add one of the other FDA-approved therapies, such as a calcineurin inhibitor or a BAFF inhibitor. Now, the fifth topic is why patients often say, I don't want to reduce my prednisone. The last time we tried, I didn't feel well, or this happened or that happened. So why isn't it always successful? Well, I think the first problem is the background therapy better be present and the patient better be taking it. Hydroxychloroquine non-adherence or non-adherence with our oral immunosuppressive drugs is very frequent. And here is one study that a whopping 29% of adolescents and young adults with lupus had undetectable hydroxychloroquine levels. Undetectable. Now, even in my patients, we found that 50% were subtherapeutic when we first introduced hydroxychloroquine whole blood levels. So I think, this is like Reagan when he said, trust but verify about nuclear weapons. Now, what's the worst thing that might happen when you taper prednisone? And I think the worst thing that's going to happen is a chance of flare. So I think we need to know how often that happens, and we need to tell patients as well. So in a systematic review, it happened 24% of the time. But the systematic review was very reassuring that these flares tended to be mild. However, I don't want to hide from you a very large randomized clinical trial of what happened when people were on prednisone 5 milligrams a day and were further randomized to taper. 27% had a flare. But 5 of the 17 flares were severe. So again, if the patient has had severe lupus nephritis, for example, in the past, severe thrombocytopenia, severe whatever, I think we need to make sure that the background therapy is sufficiently strong that they're not going to flare as we taper the prednisone. So I wanted to end with how I'm doing, because the problem when people give talks is often they state what the goals are, and they don't make it clear that it's not possible with today's armamentarium to always reach those goals. So here in green, you see my patients I've been able to taper off prednisone entirely. And then in the very light green, you see the patients that are below 5 milligrams. So let's say about 70% of my patients are reaching the EULAR goals. But 13% of my patients are on 5 to 7.4 milligrams. Remember, those would have reached the 2019 goals, but aren't really at where I want them to be. But then I have 18% of my patients, the ones in red, where their maintenance prednisone dose is above 7.5. Now, I always think I have a good reason for it, right? But no excuses. I need to do better in those 18%. And maybe I can't do better quite yet. Maybe I can get some of them from 10 to 9, for example. Remember, every 1 milligram counts. You'll never forget now how easy it is. Every 1 milligram multiplied by 3. That's the increase in permanent organ damage. Thank you very much for your attention.